Welcome back to continuing our deep dive of endometriosis. So this video we're going to begin talking about management or treatment of endometriosis. Specifically in this video we're going to concentrate on medical management. When we look at management of endometriosis, there are really sort of three forms. There's medical management, there's surgical management, and then there's management related to specific fertility issues. Like any management for any kind of disease, we need to have a think about our aims. This video will specifically focus on medical management. Medical management comes in really two forms. It comes in hormonal and non-hormonal. Really, the aim of medical management is primarily to treat pain, and some forms of hormonal management will actually suppress disease as well. As a general rule, medical management, especially the hormonal forms of medical management, is not suitable for people who are trying to fall pregnant and have endometriosis. So if we look at non-hormonal ways of management, so this is really in the realms of pain relief. So you can start with simple pain relief like paracetamol, and then non-inflammatories like aspirin, Nurofen. Paracetamol in people who have chronic endometriosis doesn't seem to be very useful. Non-inflammatories are useful in some people because, as we talked about in our last video, a key component of pain is inflammation. So non-inflammatory medications will target that inflammation, especially when used in conjunction with other forms of pain relief, can be quite effective. We then really move on to the stronger pain relief medications that really target sort of morphioid or opioid sort of receptors. So they're the morphine derivatives, though they come in many forms. You can have the weaker form like tramadol. They have morphine codeine derivatives like oxycodone, and some of its longer acting forms. Morphine, hydromorphone can be used in severe cases. The final type of non-hormonal medical management is what we call neuroleptics. So these are medications that aim to change the way nerves behave and fire. As we remember from last time, endometriosis does change the way nerves behave. They change the pain threshold, and they can also grow their own nerves as well. So these type of medications traditionally used for other purposes like depression, epilepsy. So some of these can be quite effective when used in conjunction. There are lots of good pain specialists out there who will actually manage this properly. And for people who have chronic pain, it is recommended that they get in touch with one of these teams. Moving on to hormonal management. Hormonal management comes in a few forms. So they come in looking at sex hormones, things like the oral contraceptive pill, which is generally a combination of estrogen and progesterone, or progesterone-only pills or devices. The oral contraceptive pill has the advantage of stopping periods, potentially prevent sort of that period-associated pain. I suppose the only caveat that I've always found with hormonal uses of medications that manage endometriosis, particularly its use of estrogen, is that estrogen has been well demonstrated to show proliferation of endometriosis. So for me, using estrogen as first line sometimes doesn't make a lot of sense. The progesterone component of the pill is very useful. It is being shown to inhibit endometriosis proliferation, dampen down inflammation. So progesterone-only pills can be used. More commonly and sort of more useful are progesterone-only devices like the Mirena intrauterine device. These sort of sit inside the uterus, and they release hormone that primarily makes it into the uterus itself and the pelvis rather than sort of systemically into the bloodstream. So Mirena can be quite useful in this context. There is a new progesterone that came out a couple of years ago called Denagest. Its trade name is Visane. It's a sort of fourth generation progestin which has been altered in a way that makes it quite effective for preventing inflammation, can suppress endometriosis growth and proliferation. Some patients have had very excellent effects on them. Now moving on to the second class of hormonal management. So they actually work at a level above the sex hormones. So they work at the level of signaling from the brain that stimulates the ovary to produce estrogen. These medications turn off that signaling. So the one that's been around for the longest is Zoladex. So this is what we call a GnRH analog, gonadotropin releasing hormone analog, and it basically turns the brain signal into the ovary completely off. So there is no signaling between the brain to the ovary to produce hormone. Prolonged use means that people don't ovulate as well. It's quite effective against symptomatology of endometriosis, but it also, after about 1 to 2 months use, gives terrible menopausal symptoms. And we really wouldn't recommend using it alone after 6 months without adding some hormones back to protect bones and so forth, which then potentially makes that treatment less useful. The newest medication on the market is Rieco. For me, it's actually a bit of a game changer. It's been really well tolerated by my patients. Look, I'm not affiliated with the company that makes Rieco in any way, but from my experience, I've been using it before it came onto the PBS, and it's been backed up by data overseas. From both overseas data and from my personal experience, patients have responded really nicely to it. It works in a similar way to Zoladex in that it does turn off the signal between the brain to the ovary to make hormones, but turns us off in a slightly different way. It's a little bit more reversible, it's a little bit more gentle in the way it turns it off. It also adds in a tiny dose of hormone back so you don't get any of these sort of menopausal symptoms. The data says that in its combined form, along with the sort of hormone add back, the estrogen component doesn't seem to flare endometriosis, and overall there is a nice suppression effect and there is really nice improvement in patients' pain scores.